mediastinum is divided in four compartmental model where it is divided into superior mediastinum, anti-mediastinum, middle mediastinum, and posterior mediastinum. Okay. The Felson's classification is based on the chest X-ray. Okay, mediastinum is taken as the is it okay now? Is it okay now? The Felson's classification is based on X-ray, where the X-ray is divided into three parts. Okay. This is known as anterior mediastinum, which is based on the pulmonary artery. Then urination is based on, since it is based on X-ray, it is slightly a vague classification of division. Okay. So this is the Shields classification. The Shields classification is the one which is commonly used in clinical practice, where they are divided into anterior mediastinum, posterior mediastinum. Now, are you able to hear me now?
Yes, sir, you're audible.
Okay. Accordance in the classification is the anterior. It is classified. The anterior compartment consists of thymus, internal thoracic vessels, internal thoracic lymph nodes, and fat and connective tissue. Whereas the middle mediastinum consists of all the other important aspects like the pericardium, great vessels, phrenic nerve, thoracic duct, azygous vein, etc. The paravertebral or the posterior compartments consists of the neural structures. Hence, the neurogenic tumors are common in the posterior mediastinum. It consists of sympathetic chain, the intercostal nerves, also intercostal nodes. Okay. So remember that the shield class in our clinical setting. So which are the classification system? Mediastinum is based on organographic view. Felsen. part of the recent ITMAG mediastinal classification. So the ITMG has divided into three components. One is the prevascular, the visceral, and the paravertebral compartment. The okay. So basically it is also type of the ITMG classification where there is no vascular component is there. It is the prevascular, paravertebral, and visceral compartments are there. Thoracic duct belongs to the following mediastinum: anterior, posterior, or medial mediastinum. One minute. You want to start the quiz. Okay. Someone wanted to start the class. So Filson's classification is based on X-ray. Remember this only. Okay. Filson, it is a way classification because there are no strict anatomical boundaries that are available for to describe, but still it is based on the X-ray. So the anatomical boundaries are vague. Remember that. Okay. The Shields mediastinal division is the actually commonest mediastinal classification that is commonly used. Okay. So it consists of three parts. The components of mediastinal shield is the anterior, where you have to remember the thymus is the common one. Then you can remember the visceral compartment, where the great vessels and the thoracic duct phrenic nerve are part of the mediastinal classification. Whereas the posterior compartment classification consists of the neural fibers that includes the sympathetic chain, intercostal nerves, and intercostal nodes. So the classification based on X-ray findings here is Filson. So there's another classification known as ITMAG classification, which has three compartments. One is the prevascular compartments, the visceral components, and the paravertebral components. Can you hear me? Can you
Yes,
hear
sir,
me,
you are
please?
audible.
Okay, fine. So thoracic duct belongs to the following mediastinum. As I did told, you can see that thoracic duct belongs to the medial mediastinum as according to the ITMAG classification. Don't have to remember the visceral part. You remember this anterior part where it is known as the prevascular lymph nodes, internal thoracic lymph nodes, internal thoracic vessels, thymus are part of it. Whereas the paravertebral, remember this one, the sympathetic chain. So what is the most common mediastinal mass in the children? Okay, not the neuroblastoma. So remember, the anti-mediastinum most common mass is you can include this anti-mediastinum into that. The most common will be thymus. whereas the posterior mediastinum is the neurogenic tumors are the most commonest one. By age and frequency, the children, the 40% are the neurogenic tumors. The 27% are the mediastinal neuroblastomas. 14% are the teratomas. When it comes to adults, the most common are the thymic epithelial tumors, followed by the germ cell tumors and lymphomas. Neurogenic tumors are not very much common in adults. So whenever they ask the question, the most common mediastinal mass in children is neurogenic tumor. If you want to copy it, you can copy it down. Which of the following mediastinal tumor is associated with increased risk of MEN? Good. So remember that the commonest tumor is there are many systemic syndromes that are associated with the mediastinal neoplasms. That I'm not talking about the anatomical syndromes or the anatomical representations, where like the thymoma is associated with lots of paraneoplastic syndromes. You know, the lymphoma can associate with the Bell-Epstein fever. You can see the neurofibroma is associated with Van der Klingen disease or neurofibromatosis. A thymic carcinoid is associated with multiple MEN1. MEN1 is very classical of thymic carcinoid. The neuroblastoma, you know that it can be associated with the opsomyoclonus syndrome or cocoon's eye. The neurolemonoma can be associated with peptic ulcer. So the mediastinal tumor is associated with increases of MEN is thymic carcinoid. So there are also some systemic manifestations that can occur with mediastinal neoplasms. One is you can have the carcinoid tumors can have Cushing syndrome. Then you have a neuroblastomas or paragangliomas in the thoracic cavity can cause hypertension. The parathyroid adenomas can cause hypercalcemia. Some syndrome associated with VAP can cause diarrhea. So, what is the most common anterior mediastinal mass in adults? Yeah. So, thymoma is the most common anterior mediastinal mass. The thymic masses are can be multiple types. The most common will be the thymoma. The second thing will be the thymic carcinoma. The other rare variants are the neuroendocrine tumors, like the thymic neuroendocrine tumors. Okay. Coming to, as I mentioned, 30% of the anterior mediastinal mass in adults are thymomas, whereas the thymoma constitutes 50% of the anterior mediastinal masses in children. This is very important thing. Okay. when coming to the thymoma itself, the 90% of the thymomas are located in the antemediastinum. Whereas 10% can arise in the neck or any other part of the mediastinum. Rarely it can occur in the heart also because of the embryology. The embryological derivation of the thymus causes the origin of the organ. Origin of the tumor. So most common mediastinal mass in adults is antemediastinal mass in adults is thymoma. Which of the following is false regarding thymic carcinoma? Common incidence as thymoma. Infrequently associated with the paraneoplastic syndromes. Common in men. Common in for 4 to 50 decade of life. You know, the thymic carcinoma is a very aggressive thymic neoplasm. It is like the malignant thymoma is a benign variant. Whereas a thymic carcinoma is a aggressive neoplasm. It is a poor prognosis. It is not commonly associated with myasthenia gravis or other paraneoplastic syndromes. More common in males. More common in the 80th decade of life. It is not common in the for 4th or 50th decade as it mentioned. Thymus originates from which pharyngeal pouch? So the it originates from the third pharyngeal pouch. Okay. The ectopic thymic tissue is widely distributed throughout the mediastinum and neck, particularly in the aorta pulmonary window and the retrocoronary area. That's why you will get most common the antemediastinum, where they also can occur in the neck, also can occur in the posterior mediastinum. Which of the following type of the cells are not commonly found in the in thymomas? Good. Which of the following classification system is not related to thymomas? Robson's. Robson's is used in good. Very good. So there are different classifications where the Rossi and Levine was the first one who used it as a lymphocytic or epithelial or mixed variants. So thymus is a lymphocytic organ. Remember that. The thymus, splenic, lymph nodes, all are lymphocytic tumors. They can also have a epithelial component. So this is how he first divided. There are so many classifications are there, but this is the commonly used. I mean, not the this is the initially used classification systems. So this Moreno and the Muller-Hemling classification, they called as MH. He was the one who first classified based on the location of the tumors, which subsequently helped in the development of the WHO classification, which we commonly use now. WHO classification is type A, type AB, like that it we don't know. So this was the basis of that classification. Moreno modification of Muller-Hemling classification. Don't need that. Remember that cortical types and everything. That's all. Actually, initially classified as a cortical type, the medullary type, the mixed type. He mentioned it as a cortical predominance or medullary predominance. The thymomas have a well-defined lobulated moss with a good capsule in mora in many cases. Okay. The thymic cells have lymphocytes and also has bland to moderate atypical tumor cells. Following cells are not commonly found in mesenchymal cells are not part of thymomas. The Robson classification is related to RCC. What is type C thymoma according to the recent WHO classification? Good. So this is the recent WHO classification. This recent WHO previously they had type C in the classification where they called it as a thymic carcinoma. But now the thymic epithelial type C is removed from the classification. Remember that. The type A is what to call this is a very type A is a bland cells, where the aggression is the aggressive type of I mean it is a less aggressive type of thymoma subtype. Now this is newer. Can you actually see my cursor? Are you able to see my cursor? Okay, fine. Thank you. So this atypical type A variant is recently introduced into the WHO classification. So the recent changes in WHO classification is inclusion of the atypical type A and type C is renamed as thymic carcinomas. I think this is there in the data. You can see it, but remember the few points only. We can't remember all those. So when they have a greater than 10% of the immature T cells, it is called as abundance. The type A, AB, and B1 thymomas are more likely to present with local regional disease. Compared to the WHO type B2 and B3 thymomas. It is removed in the recent classification. Coming to this important, this is very few cancers. They have this what you call this non-TNM stagings, which are very important. One is thymoma, and when it comes to gynecological cancers, the FIGO staging is very important. Pericardial involvement is stage. Any answers, please? It's okay. You answer no. You don't have to be correct. Or you do. Okay, fine. See, from exam point of view, if you have to remember, one thing about the thymoma is this Masako staging. If you remember this, because I'm going to spend some time with the staging, because the staging is vital to understand the concepts of thymoma. Masako staging is a surgical staging. I'm very sorry. I've got emergency. So this is the modified Masaka clinical staging. Remember, stage 1 is macroscopically and microscopically completely encapsulated tumors. Okay. Stage 1 is the tumor is macroscopically also microscopically limited to the within the tumor. There is no mediastinal fat involvement. Okay, this is called as stage 1. When stage 2 is microscopic transcapsular invasion, when it occurs, it's called as stage 2A. When they have a macroscopic invasion into surrounding fatty tissue or grossly adherent to, but not to the mediastinal pleura or pericardium, is called as stage 2B. Stage 2 is microscopic transcapsular invasion, which is called as stage 2A. When they have a invasion into the mediastinal fat, but which is but not adherent to the pleura or pericardium, it is called macroscopically. It is called as stage 2B. Stage 3 is here, stage 2 is adherent to the adherent to the mediastinal pleura or pericardium, but not through the mediastinal pericardium is called as stage 2. So this here to be very, very careful. When the macroscopic invasion to neighboring organs occur, they are called as stage 3. When they have stage 4, that is the pleural or pericardial dissemination, that is the pleural drop metastasis or pleural metastasis, they are stage 4A. If they have a hematogenous metastasis, it's stage 4B. So stage 3 is adherent to the pleura or pericardium. Stage 4 is pleural nodules or some pericardial nodules. So pericardial involvement is stage 3 according to Masako-Kaga staging. If it is slightly adherent without involvement, it's stage 2. When pericardium is involved, it's stage 3. Okay, remember that. Are you clear? Okay. So macroscopically and microscopically encapsulated tumors are stage 1. The microscopic transcapsular invasion is stage 2A. When macroscopic invasion confined to the mediastinum, it is stage 2B. When the stage 3 is when macroscopic invasion into the neighboring organs, that is called as stage 3. Stage 4 is stage 4A is pleural or pericardial dissemination, where stage 4B is lymphogenous or hematogenous metastasis. I hope it's clear. Now, for completion's sake, I will do the T staging, the TM staging, but it is not commonly used. What is the T staging of thymoma involving the mediastinal pleura directly without involving any other structures? Okay. What is the T staging of thymoma causing invasion of the pericardium? So the TNM staging is based on the size and also is the extension. So when there is no mediastinal pleura involvement, it is called as T1A. So remember the mediastinal involvement, mediastinal pleura. Mediastinal pleura involvement is still considered as T1. Okay, remember that. When the pericardium is involved, it is T2. T3, T4 is direct invasion of some of the adjacent organs, which you don't, you might not have to remember that. So, according to AGCC, the tumor capsule is not an actual anatomical structure. So, involvement of the mediastinal fat carries the same prognosis as the encapsulated tumor. What they want to say is that the massacre staging 1 and 2 are considered as same outcome. This is what they want to say in the AGCC. So mediastinal pleura is T1B. Invasion pericardium is T2. Now this thing you have to be very careful. What are the nodal areas of lymph node, or what are the nodal areas that are related with thymoma? Okay. What is the lymph node classification of the pretracheal lymph nodes for thymoma? BC. Can be multiple answer, no? So the the N1 or N2 is not based on the number of nodes. It is based on the location of the nodes. Okay. This is slightly a congested slide, but what I want to mention is that N1 nodes are the low anterior cervical, pretracheal, paratracheal nodes, perithymic nodes, prevascular. These are all the nodal groups that are considered as N1, that is anterior group. When the nodes are deeper location or in the cervical region, they are known as the N2 nodes. So even the pretracheal nodes in the neck are considered N1 because of its proximity to the embryological origin. Are we clear? There's not much of them, but the nodal involvement is considered stage 4A. That you have to remember. Okay. So lymph node classification of pretracheal lymph nodes for thymoma is N1. Lower paratracheal nodes, that is the mediastinum, are considered N1, whereas the upper paratracheal or the jugular nodes are considered N2 nodes. There is no N3 node for thymoma. Which of the following is false about thymic neoplasms? 40% are asymptomatic. 10% have paraneoplastic syndromes. Any guesses? %40 are asymptomatic. Usually the thymomas, 40% are asymptomatic. 40% of the patients have paraneoplastic syndrome. This is very important. 40% of the patients have paraneoplastic syndromes. So literally you have to find out I'm talking about thymoma. The false statement is 10% have paraneoplastic syndromes, which is false. What is the most common systemic syndrome associated with thymoma? Okay. What is the percentage of myasthenia gravis patients are associated with thymoma? Okay. Remember, myasthenia gravis is the most common autoimmune disorder associated with the thymoma, occurring in 30 to 50% of the patients. The incidence of myasthenia gravis is equal in males and females. We should not get an illusion because autoimmune disorder, we tend to think that it occurs more common in females. No. It is formed by the antibodies to the postsynaptic nicotinic acetylcholine receptor. It is prevalent between 40 and 60 years of age. When myasthenia gravis patient, 10% of the patients have thymoma. Remember that. In thymoma, 30 to 50% have myasthenia gravis. In myasthenia gravis, 10% of the patients have thymoma. Four to 7% of the patients with thymoma and myasthenia gravis have more than one paraneoplastic syndrome. Myasthenia gravis is rarely associated with thymic carcinoma or type A or type AB thymoma. These are all the important points which you have to remember. particularly questions from AIMS, they have lots of these mediastinal tumors. So when thymoma and myasthenia gravis, when myasthenia gravis occurs in thymoma, they are usually 10 to 15 years older than patients with myasthenia gravis who do not have thymoma. And also slightly younger than patients with thymoma who do not have myasthenia gravis. That means younger age myasthenia gravis alone occurs. In the next is thymoma and myasthenia gravis. The slightly older group would be thymoma alone. Is the speed okay, or you want me to slow down or move faster? Any feedbacks? Because I don't want. Uh, Thank you. No, because I can correct now. Little faster I can go, but some people will take time to. So the symptoms include, based on the myasthenia gravis, that include drooping eyelids, double vision, the proximal muscle weakness, hoarseness due to the range of musculature, dyspnea due to the respiratory muscles. Patients with thymomas, the treatment, I'm talking about myasthenia gravis, part of them recover with surgery, but some part of them might not recover with the surgery, where the other agent should be used. Anticholinergic agents can be used. Other problem is that before going for surgery, always search for the anticholinergic antibodies, which can be useful to find mm, the susceptibility for myasthenia gravis, even if there are no symptoms, because there are many of them, they might not come out of the anesthesia. So remission rate of myasthenia gravis after thymectomy is 7 to 63%. In severe cases, you can use IV immunoglobulins, anti-CD20 antibodies, plasmapheresis. The most common systemic syndrome associated with thymoma is myasthenia gravis. Percentage of myasthenia patients associated with thymoma is 10%. Pure red cell aplasia occurs in -% of patients with thymomas. Yeah. Okay, good. Pure red cell aplasia occurs in 5% of the patients with thymomas. Of patients with pure red cell aplasia, 30 to 50% have associated thymomas. Just compare with the presence of myasthenia gravis also. So thymectomy might not be useful, but many times where remission occurs. Good syndrome is the thymoma associated with the following neoplastic syndrome. Okay. The hypergamma is seen in 5 to 10% of the patients with thymoma. So thymectomy might not be very useful, but for the oncological purpose, we can give, and then you have to treat the hypogammaglobulinemia. 10% of the patients with hypergammaglobulinemia has been shown to have thymoma. There are other neurological paraneoplastic syndromes are present. One is the neuromyotonia, where it's also known as Marban syndrome. Is frequently found in patients with thymoma. I have taken most of these presentations from Devita and also from Shields General Thoracic Surgery. And also Sabistan's Thoracic Surgery book is there. From that also I have taken out. So remember, the slide is to tell you that it can be associated with variety of paraneoplastic syndromes. The hematological syndromes, which we already discussed, that includes the pancytopenia, red cell aplasia, hemolytic anemias, the neuromuscular disorders, which we known as myasthenia gravis, etc. Can have a variety of syndromes. There are also syndromes that are associated with collagen disorders like SLE, Sjogren, rheumatoid arthritis, polymyositis, myocarditis, sarcoidosis, ulcerative colitis. Endocrine disorders like Hashimoto thyroiditis. Which is the most common autoimmune disorder associated with thymoma? That means lupus is common. Pure aplasia occurs in 5% of patients with thymomas. Good syndrome. What happens? Someone good syndrome is associated with hypergammaglobulinemia. Some of the written it, I don't know. Can you just remove this scribbling? Postoperative radiation is neither in stage 1 and stage 2 time, Mama Masaka. Which of the following is true? Coming to surgical mortality, as I told, all patients should have their serum anti-acetylcholine receptor antibody levels to find out the risk for respiratory failure during surgery. The imaging CT is the ideal imaging modality. You don't need PET CT, otherwise you have a suspicious findings for the extra mediastinal disease. The CT, the well-lobulated mass is a very good finding for that. Based on the clinical and the radiological features, you can go ahead for the resection. So the main aim is to achieve R0 resection. There are various approaches. One is the mediastinal approaches. When the tumor is small and more than the upper mediastinum, you can plan for the transcervical thymectomy also. But in exam, they won't be asking that. That's why they concentrate on the surgical approaches. Because I'm not taking class for I'm taking class for the entrance. So all the concepts will be only based on the entrance questions, most of them. When you need, there are cases which you might need extended total thymectomy, which needs a resection of some of the part of the organs. It might be required in the up to 2/3 of the cases. If you find, always search for the pleural surfaces to find any pleural metastasis there or not. If feasible, resection of pleural metastasis to achieve complete loss resection is needed. So post-operative radiation therapy is not recommended for stage 1 or 2 tumors. I'm talking about Masaka staging. If audio resection is achieved, no need for any adjuvant treatment. Very clear. So incomplete resection needs post-operative radiation. The post-operative chemotherapy is needed in stage 3 and 4 thymomas. When you have stage 3, you can go for neoadjuvant chemotherapy followed by surgery. Yes, RT also given. But the variation after the this is very difficult to give because of the heightened structures that are there in the mediastinum. Definitely, that's a go. So coming back to is post-op variation is needed in stage 1. Needed in all cases of stage 1 and 2? No. Needed in all cases along with chemotherapy? No. Because it's a chemotherapy, the use is starts only in the stage 3. Needed from stage 2 onwards? No. R1 dissection needs radiation. So coming to the adjuvant treatment, the adjuvant treatment 45 to it is a 50 gray for the clear or closed margins. 60 to 70 gray should be given to patients with R0, R1 or R2 disease. So the chemotherapy regimen is a cisplatin, adriamycin, and cyclophosphamide. So timoma, you know, when it is arduous resection, you don't need any treatment. When you have a very, I mean, this is slightly confusing thing. You don't need to know that. Which of the following is considered as the most important prognostic factor? Completeness of resection, age, tumor size, or myasthenia gravis. Yes, definitely. So the stage and completeness of the resection are considered as the most important factor. The gender is non-prognostic. There is no gender difference in the prognosis. Myasthenia gravis is not associated with any prognostic thing. Tumor size, age, not much of literature. So completeness of resection and stage are considered as the most important prognostic factor in thymoma. What is the 5-year survival of stage 1 thymoma? So thymoma is a benign tumor. If you can do a good arduous resection, the survival is very good. because the recurrence is slightly lower. Stage 1 is 90%, stage 2 is 80%, stage 3 is 60%. Basically, this tabular column is to show how good is the tumor. Now you have to understand the difference between thymoma and thymic carcinoma. Okay. Which of the following is false about thymic carcinoma? Have same prognosis as thymomas. Paraneoplastic syndromes have same incident as in thymomas. Basaloid carcinoma is the commonest. All of the above. What is the most common genetic expression found in thymic carcinoma? So there are various types of thymic carcinoma subtypes are there. One the thymic carcinoma subtypes includes the squamous cell carcinoma, basaloid carcinomas, lymphoepithelioma like carcinoma, sarcomatoid carcinomas. There are so many of thymic carcinoma subtypes are there. So of this, remember this one, the low-grade malignancies are well differentiated squamous cell carcinoma, basaloid carcinoma, mucoepidermoid carcinoma, large cell carcinoma associated with Castleman's disease. So, thymic carcinomas are associated with different clinical course from thymomas. As I already mentioned, the paraneoplastic syndromes are uncommon in patients with thymic carcinoma. You know the thymomas occur in the 6th to 8th decades or 5th to 7th decades like that. But the thymic carcinomas can occur anytime, but including adolescents, they are common. Most common is squamous cell carcinoma. When it comes to molecular abnormalities, the thymic carcinoma CK2 overexpression is found in 75 to 85% of the patients. So all of the above all is the wrong answer. The thymic carcinoma also needs post-operative, even in stage 1 or 1 also needs post-operative radiation. In thymic carcinoma, early stage tumors have a better prognosis. Lymphoepithelioma like histology, although it is a high grade, it has a good prognosis if you treat well. Lobular growth pattern is associated with improved survival. Now coming to the thymic neuroendocrine tumors, which are the following paraneoplastic syndrome is commonly associated with thymic neuroendocrine tumors? Thymic neuroendocrine tumors, they occupy less than 5% of the thymic neoplasms. They occur more frequently in men than in women. Commonly associated with Cushing syndrome. Thymic carcinomas, 73% can have regional lymph node metastasis or distant lesions. So any neuroendocrine tumors are classified into typical carcinoids, atypical carcinoids, or high-grade thymic carcinomas. Like in lung, we divide no typical carcinoids, atypical carcinoids, or small cell carcinoma, like that. I'm not going to detail into it, but usually neuroendocrine tumors are better treated with surgery. Carcinoid tumors. When you have a stage 4 disease, if they are slow progressing, you can go for somatostatin analogs. It's common for more or less all the neuroendocrine tumors that has been extrapolated from the pancreatic neuroendocrine tumor guidelines. Which is false regarding thymolipomas. Any guesses? Good. Thymolipomas, they are 1 to 5% of the thymic neoplasms. They are benign neoplasms. They can be associated with paraneoplastic syndromes, but less incidence and comparable to the thymomas. Malignant transformation does not occur. Treatment is complete resection. Frequently, in chest X-ray, they can be called as the draped along the diaphragm. Basically, the lipoma goes in spaces where they can expand. So they can go where the inferior space, anterior-inferior space is slightly lower, where they can be connected, known as draped along the diaphragm appearance. So which is false regarding the thymic lipomas. They are benign. Malignant transformation is rare. Paraneoplastic syndromes are common. All are true except it occurs equal among the genders. So coming to thymic cyst, to a couple of slides about thymic cyst. Remember, there are two types of thymic cysts. One is unilocular, another is multilocular. So unilocular and multilocular. Unilocular is more or less a developmental abnormality. They definitely contain thymic tissues always present. They occur from the remnants of the thymopharyngeal ducts. Whereas the multilocular cysts are usually occur in the thymus in the adult group most commonly. They can be due to the inflammations due to acute conditions. Any doubts in thymoma? Are you clear about thymoma? If you go and read 1 second, you will be able to finish it completely. Because this thoracic tumors, they definitely consume lots of time to read. Now, if you go and read once, it will be a good hold of it. Because you have to be very careful with some topics, thoracic tumors, uro-oncology, because these are the areas if you have to spend lots of time now, because nailing exams is very difficult to allot lots of time for these topics. If you're able to spend, because it's now relatively a free time for you to prepare, if you're able to spend lots of time understanding these tumors, it's easier to revise. You cannot see. You can read breast near the exams. You can read GA near the exams because you already have the concepts. But this thoracic uro-oncology are totally not related uh, to the MS curriculum. It's better to understand now and read, take notes, and keep it prepared for yourself. Any doubts? Any doubts you have? Is it okay? Are you awake?
If you have any doubts, you can ask in the comment section.
I hope it's yes, sir, is for the question for the whether you are awake. Okay. Okay. Shall I proceed to other topics? Regarding mediastinal germ cell tumors, which is true. Any answers? See, the mediastinal germ cell tumors, 2 to 5% of all the germ cell tumors. Most common is the testicular tumor. Then you can have a retroperitoneum. Then you have mediastinum. Then very rarely you have in the midline in the pineal gland also. Okay. It consists 2 to 5% of all germ cell tumors, mediastinal germ cell tumors. 50 to 70% of all the extragonadal tumors. They constitute 10 to 15% of all the primary mediastinal tumors. The truth is 50 to 70% of the extragonadal germ cell tumors are the mediastinal germ cell tumors. Are you clear with this slide? Which are the following is a true statement? Benign germ cell tumors are less common than malignant germ cell tumors in the mediastinum. Malignant germ cell tumors usually occur in the first decade of life in the mediastinum. Benign germ cell tumors are common among the males in the mediastinum. What is the most common mediastinal germ cell tumor? Yes, good. Anterior mediastinum is the most common extragonadal location for the germ cell tumors after the testis. 15 to 20% of the anti-mediastinomas are germ cell tumors, usually divided into benign and malignant lesions. So the most common mediastinal germ cell tumor is a benign teratoma. It constitutes 70% of the mediastinal germ cell tumors in children, and 60% of mediastinal germ cell tumors in adults. Usually they can have, but teratomas can present, can have a multiple different tissue types like teeth, fat, muscle, bone, or anything. Based on that, you can have calcifications. So malignant germ cell tumors occur between 20 to 40 years of age, usually. Primary pure mediastinal seminomas are the 35% incidence. %90 of malignant mediastinal germ cell tumors occur in men. Remember that teratoma does not have a gender predilection, but these mediastinal germ cell tumors have gender predilection. So benign germ cell tumors are commoner than malignant germ cell tumors in mediastinum. Malignant germ cell tumors usually occur in the second to fourth decade of life. Benign germ cell tumors is common among the males. No, benign germ cell tumors is equal among the genders. Most common mediastinal germ cell tumor is teratoma. The malignant components can also rarely have a associated other malignant components like adenocarcinoma, squamous cell carcinomas also can present. Remember this part. This acute megakaryocytic leukemia. This acute megakaryocytic leukemia is typically associated with this the mediastinal germ cell tumors. So most of the mediastinal germ cell tumors have systemic disease at the time of diagnosis. Okay. The seminomas have respond well to both radiation and chemotherapy. But in this mediastinum, because of the location of tumor, you have vital structures including the heart and the other vital structures where the radiation you might not be able to give completely. In practical purpose, seminomas are usually treated, mediastinal seminomas are usually treated with radiation. Surgery does not play a role in the management of seminoma. No, they usually respond well to chemotherapy and radiation. Usually, a unimodal modality treatment is enough. The teratomas are benign. You can't give any other treatment unless they have a immature teratomas. Teratomas are usually treated with surgical resection. Can someone remove this line? I think someone has scribbled here. I'm not able to. Who had scribbled? Can someone delete this blue line? The non-seminomatous germ cell tumors, testicular tumor itself, there is no role for radiation. Chemotherapy is the main role. Chemotherapy plays main role. Usually we go for BEP regimens, 4 cycles. There is an international staging system for germ cell tumors, where there's classify into low risk, intermediate risk, and high risk. Seminoma has only 2 risk factors. One is low risk and intermediate risk. There is no high risk for the seminomas. The mediastinal seminoma falls under the intermediate risk category. This might be a question. Which is true of nut midline carcinoma. It is not neutral protein. It is a nuclear protein in testis midline carcinoma. They are usually poorly differentiated squamous cell carcinoma. They have virulent growth. So nut midline carcinoma is resistance to cytotoxic. Sorry, there's a mistake here. So indolent growth is the answer. Sorry. It's a resistance to cytotoxic chemotherapy. Which of the following is a true statement regarding mediastinal neurogenic tumors? Neurogenic tumors of the thorax commonly occur in the posterior mediastinum. As I already mentioned, neurogenic tumors are the most common malignant neoplasm in children. in adults, the malignancy rate is 10%. Whereas in children, 50% are malignancy. No, please don't scribble. It's in children, 50% of lesions are malignancy. So the neurogenic tumors are classified based on the origin, where the intercostal nerve tumors can have neurofibroma, neurolaminoma, neurofibrosarcomas. Whereas sympathetic ganglion tumors can be classified as ganglioma, ganglion neuroblastoma, or neuroblastomas. The paraganglial cell tumors are classified as a paraganglioma, extraadrenal paragangliomas. The nerve sheath tumors, 25 to 40% of them have neurofibromatosis 1 type. The neurogenic tumors originate from embryonic neural vessels near the spinal ganglia. So answer for this is neurogenic tumors are common among children and adults. Not the most of the mediastinal tumors. Most of the mediastinal tumors adults are benign. Only 10% are malignant. It is 50% of pediatric mediastinal neurogenic tumors are malignant, not 20%. Okay. Coming to mesothelioma, the last topic of it. Then I will take the lung cancers. So malignant mesotheliomas are highly aggressive neoplasms that arise from the pleura, peritoneal, pericardial cavities, or even from the tunica vaginalis. Which is true about mesothelioma. Okay. Most mesotheliomas occur 6 to 8 in the 6 to 8th decade of life. There is always 25 to 40 years latency period between the occupational exposure and the development of the tumor. The male to female ratio is more common among male because of the more exposure to asbestos. So commonly, it commonly affects the pleura. It commonly seen in men. Usually affects the age between 50 to 70 years of age. Usually occurs 25 to 40 years after the asbestos exposure. Clear? Which of the following is not amphibold asbestos? The 5 times other than the chrysolite are termed as amphibold asbestos. Usually there is asbestos, they go into lungs, they cause chronic inflammation, they cause a release of the high mobility group box one marker that causes engulfing of the asbestos, leading to the chronic pathology. There are also two other risk factors that three risk factors. Other three risk factors that have been implicated with the development of mesothelioma. One is simian virus 40. Now it is not there, but previously when in the 1950 to 1960s, when the polio vaccines were administered from the rhesus monkey, there had been reported cases of malignant mesothelioma. Also, there had been risk factor associated with radiation, particularly for the lymphomas, Wilms tumors, or mantle cell radiation that had happened in the past. But major proportion are due to the asbestos. Remember, smoking is not a risk factor for mesothelioma. Isolate is not a factor. There you have to remember that there are some benign mesothelioma also, which are known as adenomatoid mesotheliomas, multicystic mesotheliomas, well-differentiated papillary mesotheliomas, localized mesotheliomas can occur. Okay. But what we are concentrating is the malignant variant. So the peritoneal mesotheliomas are less frequently associated with the asbestos exposure. A subset of mesotheliomas are associated with ALK rearrangements. Usually mesotheliomas have two basic types. One is a epithelial morphology, and another is sarcomatoid morphology. Sarcomatoid morphology is very aggressive. They can have biphasic type, which occurs 30 to 50% of the patients. So what is the most common morphology? It is the epithelial morphology. Remember that Win's tumor 1 is the most specific immunohistochemistry marker for the pleural mesothelioma. Mesothelioma cells are diffusely positive for pankeratin, keratin fiber 6, calretinin, and WT1 gene. Common genetic abnormality associated with mesothelioma is the BAP1 gene. That is the BRCA1 associated protein gene. There are also other two tumor suppressor genes that are associated. You have to remember the neurofibromatosis 2 gene or Merlin, or you can have cyclin dependent kinase inhibitor 2A, that is CDKN 2F, 2A or EARF, alternate reading frame, that occurs in 40 to 50%. Sorry, there's a small clerical mistake. It's a BRCA1 associated protein. So that I was telling about there are 4 risk factors. One is the asbestos, which I already discussed, radiation, then simian virus 40, then there is a hereditary component is there. Which of the following is part of BAP1 syndrome? BAP1 cancer syndrome is associated with mesotheliomas, uveal melanomas, clear cell renal cell carcinoma, basal squamous and cutaneous melanoma. So the answer for that is all of the above. Remember that mesothelioma in germline MAP1 mutation, in BAP1 gene mutation, they behave better than the sporadic mesotheliomas. Epithelial, they usually present with epithelial type, well differentiated tubular and papillary structures, less invasive and less aggressive. Usually, it is a chronic disease. They grow slow. Many of them they present with non-pleuritic chest pain that is located posterolaterally and low in the thorax. Dyspnea occurs in 50 to 70% of the cases. There are serum biomarkers that are commonly associated include mesothelin, osteopontin, fibulin 3, or the frequent biomarkers that are associated with the mesotheliomas. The CT picture usually shows pleural plaques, diffuse pleural thickening, with or without pleural effusion. I don't think I have CT. Yeah. Okay. PET-CT is useful only for to find out the distal metastatic disease. This is a TNM staging, but you don't have to uh, very much testing. Usually, when the disease is confined only the pleural cavity, it is called as T1 tumor. When there is involvement of the lung or the visceral pleura, they are considered as lung or the underlying muscle, it is considered as a T2 tumor. When they have involvement of the mediastinal flat, endothoracic fascia, where they are potentially resectable, they are known as T3 tumors. Remember that. Notes you don't have to remember. What is the management? Management is based on the patient's performance status. So surgery is indicated when there's a stage less than 3B. What is the surgery? Surgery is to aim at obtuse resection. If you can't achieve obtuse resection, you can do what is called as maximal cytoreductive surgery or cytoreduction. So the definitions, the surgical procedures for malignant pleural mesothelioma can be extrapleural pneumonectomy, which is actually a very radical procedure. Then you have a pleurectomy or decortication. You can have something in between that is known as extended pleurectomy or decortication. You can have partial pleurectomy. So if you remove everything out the pleura, pericardium, and ipsilateral hemidiaphragm and the lung, they are known as extrapleural pneumonectomy. So the pleurectomy and decortication is removed. So removal after only the pleura. The extrapleural pneumonectomy includes the removal of the lung, the pericardium, part of the diaphragm. So the extrapleural pneumonectomy, you need a very high center volume. You need very good fitness of the patient. You have to choose the patient ideally for the extrapleural pneumonectomy. Always do mediastinal nodal dissection. So there are two important prognostic factors. One is the sarcomatoid histology, which we already discussed, and the lymph node involvement or the considered as the poor prognostic factor. So when you are done a very extrapleural pneumonectomy, you don't need any postoperative radiation. But in lung sparing surgery, you might have to give radiation, but it's very difficult to give to the thoracic part, particularly in the mesothelioma, where the large area is needed to be part of it. For unresectable patients, then you have a chemotherapy that is the cisplatin and pemetrexed. There are also immunotherapy options that are available are pembrolizumab and then nivolumab. It's for completion sake. Remember, the mesothelioma needs surgical resection extensively, where you need where they are classified based on the extent of the surgical procedure. Thank you. Any doubts in that? Any doubts?
The screen is not shared.
Hello?
Your screen is not shared.
Hello?
Your screen is not shared.
One minute, 1 minute, 1 minute. I'm just having 1 minute. When you want the lunch break? You want now or you want after some time? Okay, the lung cancer will be around 2 hours class. We will just take a 5 minutes break. Okay, we will be back by 12:45, and then I will take 1 hour. Then 1 hour by then we can take a. Then we can continue after lunch also. Okay,
Okay,
is that
sir.
okay?
We'll start after 5 minutes, 5 to 10 minutes.
Yeah, yeah, sure. 12:45 we'll start. Thank you.
sir, we can start.
Hi, everyone is back. Okay. Now, the lung cancers, it's a very vast topic, but I'm taking only from the exam point of view. Okay. I will tell the few important concepts for you to understand about the lung cancers. Okay. So that you can read and understand and do that. Okay. So now I'll start with a few cancers. A few questions. I wasn't able to form questions for all the thing. All the descriptions, but I will try to engage you with the questions. Okay. Remember that there are a few terminologies you have to understand. One is ever smoker, the never smoker, the current smoker, and former smoker. Okay. An individual who has smoked 100 or more cigarettes during his or lifetime or considers ever smoker. Never smoker is an individual who has smoked fewer than 100 cigarettes during her lifetime is never smoker. Former smoker is who had quit more than 12 months earlier are known as former smokers. Okay. Now, you have to find out the difference between lung cancer in ever smokers and lung cancer in never smokers. One minute. Some video problem. Okay. The lung cancer in never smokers are usually adenocarcinomas. Okay. The other terminology, the other factors that ever smokers might have lots of the higher ratio among women for the among the never smokers. There are also genetic focus that are associated with ever smokers. There are people who smoke for the decades, but they still have a lesser chance of lung cancer. Whereas the people who have a short a back duration will have a higher incidence of lung cancer because of the genetic abnormalities, that is the RGS17 locus and polymorphisms. So the lung cancer in never smokers, remember, it is largely adenocarcinoma. And this thing, lung cancer in never smokers have G2T transversions are more in lung cancer in never smokers. Don't have to remember everything about this, but remember that thing. Coming to etiology, almost 90% of lung cancers have strong association with smoking. %10 of the lung cancers occur due to occupational hazards, particularly related to asbestos, radon, cadmium, chromium, beryllium, nickel, arsenic, and vinyl chloride. The outdoor air pollution causes 1 to 2% of the lung cancers. There are also chronic inflammatory diseases like COPD, interstitial lung diseases, idiopathic pulmonary fibrosis, or associated with the lung cancers. These are the various agents that are associated, various industries that are associated with it. Now, coming to the lung cancer screening, there are two criteria: NLST, National Lung Screening Trial, which shows that patient who are between 55 to 74 years with greater than 30 pack years, who quit less than 15 years are candidates for lung cancer screening. They have shown that with the screening, there has been 20% reduction in the lung cancer mortality. There is 6.9% of all cause mortality reduction. We have to screen 320 individuals to save one patient for lung cancer death. Okay, remember these results. There's a 20% lung cancer mortality reduction with low dose CT screening. Now the scoring systems, that is the lung rats. Like you have BI-RADS, for lung, you have lung rat scoring. Okay, which shows that the distribution of the risk of malignancy. Sorry. Okay, when the lung rat score is up to 2, you can just continue annual screening with low dose CT for annually. When you have lung rat scoring of 3, you have to do a 6-monthly CT. When you have lung rat score of 4A, you can do a 3-monthly follow-up to find its growth, or you can do a PET-CT if there is a greater than 8 mm solid component. This is basically the guideline which we do for a lung cancer screening and its interpretation. So solid nodule in a CT chest is very, very, very important. Anything about 5 mm needs a solid nodule. I'm talking about solid nodule. Anything 6 mm or above needs intervention or chronic follow-up. Please, can someone remove this mark? I think it can be removed by someone who had scribbled it. Can someone remove this one? I think in your okay. The partial solid nodule also needs a very strong stringent criteria for further evaluation. The non-solid nodule can be observed if it is up to 20 mm or 2 centimeter. So you have to the lung screening depends on the size of the nodule and also the character of the nodule. What is false about cigarettes? So cigarette smoke is a complex aerosol. Nicotine is the determinant of addiction. It is not a causative of malignancy. Tar is the particulate residue that is left behind. So the tobacco-specific N-nitrosamines play and polycyclic aromatic hydrocarbons play an important role in the carcinogenesis. So mentholation actually increases the intensity of the smoking. So mentholation decreases the risk of lung cancer. No. Mentholation increases the intensity, subsequently it increases the risk of lung cancer. So we already mentioned there are also some other risk factors that includes radon gas. Also, the CT also causes some increased risk for cancer. That's why even for screening we use a low dose CT scan. Coming to non-small cell lung cancer. The non-small cell lung cancer commonly are adenocarcinomas, squamous cell carcinoma, adenosquamous carcinoma, large cell carcinomas, and sarcomatoid carcinoma. There are very clear pathological guidelines for that. Remember, the lung cancer, the histological spectrum has changed. Since there have been a steady decrease in the smoking, which has reduced the incidence of small cell lung cancer. So adenocarcinoma is the most dominant type. Coming to the staging, when the tumor is lesser than 3 centimeter, it is a T1 stage, which has been divided into T1A, T1B, T1C, and also T1 mic. When T2 tumor is size greater than to 5 centimeter, or tumor involving visceral flora or main bronchus. Usually they ask this one, T3 tumors. T3 tumors are tumors that causes invasion of chest wall, pericardium, or phrenic nerve, or separate tumor nodules in the same lobe. Okay, this is what they commonly ask. If it is in the different lobe, it is known as T4. If it is in the same lobe, it is a T3. When the recurrent nerve is involved, it is T4. Okay. Just remember this 4. Then any other thing you can manage. So, involvement of subcarinal node, it is N2. Okay. N2 lymph nodes. So mediastinal lymph nodes is N2. This is all there in the data. I'm going to. Don't need to know all that. So when you have combined malignancy, when adenosquamous carcinoma, when there should be at least 10% of the tumor should have the particular component to say that it is adenosquamous carcinoma. Okay. This is very important because we will be talking about combined small cell and non-squamous cell carcinoma, where there is not a 10% is not required. Even a percent it is called as combined. %. Remember 10%. See, this is adenocarcinomas which have been divided into pre-invasive lesions, minimally invasive adenocarcinomas, invasive adenocarcinomas. Okay. Remember that minimally invasive adenocarcinoma is when they have a less than 3 centimeter lipidic predominant tumor with greater than 5 mm invasion. There are also subtypes. Sarcomatous carcinoma can be of various subtypes. Sarcomatous carcinoma is also known as metaplastic carcinoma. They can have a pleomorphic carcinoma, or they can be classified as carcinosarcoma or pulmonary blastoma. Depends upon the components of the tumor. Pleomorphic carcinoma is a poorly differentiated non-small cell carcinoma that contains at least 10% of the spindle or the giant cells, known as a pleomorphic carcinoma. Carcinosarcoma consists of carcinoma and sarcomatous elements. Like rhabdomyosarcoma, chondrosarcoma, or osteosarcoma. Pulmonary blastoma consists of biphasic tumor that consists of fetal adenocarcinoma and primitive mesenchymal stroma. This slide is very important. Okay. For immunohistochemistry analysis, the lung carcinoma, for lung adenocarcinoma, TTF1 and napsin A are the markers. Lung and squamous cell carcinoma is positive for P40 or P63. So when you have a diagnosis with the subtype pathologically, you can do two markers, that is TTF1 and P40, to classify whether they are adenocarcinomas or squamous cell carcinoma. So TTF1 is positive in 70 to 90% of the adenocarcinoma. Usually the metastatic adenocarcinoma lung is always negative for TTF1, except in thyroid malignancies where they can be positive. The questions around this area are common. So napsin A is positive in 80% of the lung adenocarcinomas. What is definition of solitary pulmonary nodule? Yes. Solitary pulmonary nodule is defined as a solitary lesion less than 3 centimeter in diameter, surrounded by normal lung, and not associated with any other abnormalities in the thorax, such as lymphadenopathy or pleural effusion. Less than 3 centimeter and not associated with any other morphological changes in the thorax. PET is usually helpful except in ground glass opacities. Carcinoma tumors, typical carcinoma tumors also PET non-avid. So PET should not be used for lesions that are smaller than 1 centimeter or for a ground glass opacity. What is the false positive rate and false negative rate for lymph node identification in the PET CT scan in lung cancer? Any guesses? Which are the following are not N2 nodes in the mediastinum? So usually in lung cancer, what is very important is mediastinal staging. The mediastinal staging is to find out the exact nodal status in the mediastinum. So we can identify the one radiologically, but still if there are any suspicious suspicion nodes are there, or any if there are no nodes, then we have to go for a invasive technique to identify the node status. Usually, you can do a endoscopic with a endoscopic ultrasound, that is to the esophagus, or you can go to the endobronchial ultrasound. You can go for a blind transbronchial needle aspiration, but it depends on the location of the nodes. It's very difficult. Different modalities of mediastinal staging can occur. You can go for the mediastinoscopy, which is commoner. Usually, endobronchial ultrasound with needle aspiration is the first investigation of choice. Mediastinal staging is done for all the cancers, non-small cell cancers. If you're planning for go straight away surgery, you can go ahead. If you if you have N1 nodes or small nodes, you can straight away go do the primary surgery along with the lymph node dissections. Okay, but when you have a suspicion nodes, you want to prove whether they have a N2 nodes. What you can do is you can do a mediastinal staging by invasive methods. There are various methods to do that, as I mentioned. It can be done with the endobronchial ultrasound and with the bronchial ultrasound guided aspiration. You can go for mediastinoscopy. You can go for the VATS also. The previous techniques were just simple blind transfer bronchial needle aspiration, particularly for subcarinal nodes, they are useful. So all the lung cancers need some sort of node, nodal staging. If you're doing a primary surgery, you could do that. If you're doing if you're planning for a preoperative chemotherapy, you want to do the tissue, then you can do a FNAC or tissue diagnosis. If they are very large nodes, you don't have to do, like 3 centimeter nodes or like that, you don't have to do. It is implied. Is it okay, Mr. Lakshit Tomar? Is it okay? Have you got the answer? Def Definition of suspicious lymph node is based on the character. One is size is 1 centimeter. Another is shape of the node or oval nodes. Any PET-CT uptake nodes, you have to be very, very careful. Okay. So this one is very important because you have to they are classified as N1 nodes and N2 nodes. Okay, because of the the location of the nodes. Okay, so when you have a higher mediastinal nodes, you see there are two areas you have to remember the stations. One is the station in the gastric cancer and the station in the lung cancer. There are not much of stations that are available. Okay. Remember that station 1 is the highest mediastinal. Okay, that is present usually about the brachiocephalic artery. The level 2 is divided as a 2R or 2L, right side or left side, upper paratracheal. Here you can see that upper paratracheal 2R, this is 2L. Okay. Stage 3 is prevascular. Four is lower paratracheal. Five is subaortic. You can see subaortic. Six is paraortic. Station 7 is subcarinal. Okay. If you remember like that, you will be able to remember long term. 8 is paraesophageal. 9 is pulmonary ligament. These are all N2 nodes. The N1 nodes are when you go into the lung or around the lung. the hilar lymph nodes, the interlobar lymph nodes, lobar lymph nodes. Then further they are classified into segmental, subsegmental. So remember this one. There might be some questions that can be asked. See, this is the I was telling about the mediastinal, invasive mediastinal. There are some areas which you cannot do with all the systems, but remember this one, the mediastinal Chamberlain procedure is useful for 5 to 6 lymph node sampling. The traditional mediastinal scope has a very primarily they are useful in anterior regions. Always remember this subbiotic and paraiotic stations are very difficult to assess, particularly the 6. So remove the lymphatic lymph node stations. So the false positive and false negative rate of for lymph node cancer PET-CT scan is 20%, both of them. N1 hilar lymph node is a N1 node. What is ideal treatment of stage 1 non-small cell lung cancer? So remember, for clinical 1 non-small cell lung cancer is surgical resection. It should be ideally, if it is possible, do a ideal anatomical resection, that is lobar resection, along with formal systemic lymph node sampling or lymph node dissection. What is the treatment modality for stage 2 or N1 positive tumors? It is N1. N1 you can operate. N1 or those hilar knows everything, you can straight away operate. That is, it needs a surgical resection. The formal mediastinal node dissection is needed. Adjuvant chemotherapy is indicated in stage 2B. Postoperative radiation is not routinely recommended. What is the modality of treatment for T3N0 or N1? Non-squamous cell carcinoma. When involving the chest wall, you can go it with surgical resection. But adjuvant chemotherapy is indicated. Post-operative chemotherapy with radiation. Sorry, there's a critical mistake. Remember some few things about the surgical treatment in non-squamous cell carcinoma. Always do anatomical resection. Non-anatomical resection or sublobar resection is can be done when you have a poor pulmonary reserve or peripheral nodule which is less than 2 centimeter in pure adenocarcinoma in situ histology. Nodule has a greater than 50% of the ground glass appearance on CT. And the radiological surveillance confirms greater than 400 days of doubling time. Preferably do a lung sparing procedure. Pneumonectomy can be avoided unless the tumor is large or in the center quadrant. VATS, video assisted thoracic surgery, is found to be equivalent in oncological outcomes if it is done in an ideal center by ideal surgeon with experience in VATS. Ideally, the lymph nodes sample should have a N2, the mediastinal node should be mapped. At least 3 N2 stations should be sampled or complete lymph node dissection should be done. Before deciding on the treatment, one thing which we have to remember is we have to give our best effort to find out whether they have N2 disease or not. Okay, that is very important. If N2 disease is there, it's preoperative. If you can identify it, better to go for preoperative therapy followed by surgery. Is it very clear? So the goal will revolve around finding the N2 disease. That's why this N2 disease, we will try to go for mediastinal staging using various techniques. You have opened the chest. Now you are finding a N2 node. If you open the chest, if you can resect it, do a formal lymph node dissection. You could not identify N2 node preoperatively. So you have opened the thorax. Now you are finding it. Then you can do that. But if you're undergoing that, then you don't have to worry about morbidity. You can just close it and come back, and then you can give preoperative therapy, and then you can go and operate. So always to avoid these complex situations, always use your maximum efforts to find out the N2 nodal disease preoperatively. The preoperative treatment can be preoperative chemotherapy or preoperative chemoradiation. Preoperative chemoradiation is associated with higher rates of pathological complete response and negative mediastinal lymph nodes. This is the important thing. If you find N2 disease, better to have preoperative chemotherapy after confirmation of N2 disease. If you are not, if it's unresectable disease, you can go for a definite chemoradiation. This is a very important slide. When the patient performance status is poor, you have very small tumor, you cannot go for surgical modality. Then you have two options. One is you can go ahead with ablative treatment, or you can go with a SBRT. So the ablation can be done when the tumor is less than 3 centimeter, preferably less than 2 centimeter. Or if patients who have undergone the previous treatment, ablation can be attempted. For a local regional recurrence, if it is possible, you can do that. So image guided thermal ablation is classified as a radio frequency ablation, can be microwave ablation, can be cryoablations. So the objective criteria of the high risk patients include high risk patients, like the major criteria. When you have a forced expiratory volume at 1 second, or the DCLO is lesser than or equal to 15%, or the absolutely difficult to operate. So these are the patients, or you have minor criteria. You have either single major or two more minor criteria. So these are the patients where it will be very difficult to do a lung surgery. In those patients, this ablation can be attempted. Usually, this adjuvant treatment revolves around cisplatin. Okay. If it is non-squamous, you can go for cisplatin and pemetrexed. Don't have to remember dose and all. Just remember the non-squamous revolves around cisplatin and pemetrexed. If it is squamous thing, you can go for cisplatin plus docetaxel or gemcitabine. Four cycles usually. There are also protocols for the concurrent chemoradiation. Better to go for concurrent chemoradiation than the sequential chemoradiation. Pancreas tumors all are true except Usually, pancreas tumors or lung cancers that invade the structures in the thoracic inlet. Standard treatment for localized cancer pancreas tumor is concurrent chemoradiation followed by the surgery. Horner syndrome is usually not part of the pancreas tumor. So metastatic lung cancer, I'm not going into detail, but one thing you have to remember that there are lots of molecular agents that are available in the treatment of metastatic lung cancer. So when you're planning for metastatic lung cancer treatment, always remember that you need a lots of gene identifications or genetic markers identification for various drugs to be used. Okay. Remember that they have lots of around 40% will have epidermal growth factor receptor issues where the drugs can be targeted here. The drugs can be targeted in the KRAX. Drugs can be targeted in the AL pathway. So EGFR is a receptor tyrosine kinase. Usually 40 to 60% will have, I think 30 to 50% will have positivity for the EGFR, which where you can use the tyrosine kinase therapy. Usually the smoking status, ethnicity or histology are associated with the presence of an EGFR mutation. Anaplastic lymphoma kinase gene is another treatment which can be used. Markers. So these are the targeted therapies that are approved. It's available in the textbook. So this slide is important. Sorry for the slightly poor quality. Okay. This EGFR, if a targeted therapies are used, you can use erlotinib, geftinib, afitinib, and asthma. Osimertinib can be used. For ALK treatment, you can do crizotinib, kevintinib, and alectinib. ALK, you can use crizotinib, alectinib, begatinib. EGFR, you can use geftinib commonly used. You can take erlotinib, cetuximab, you can use. When there are no targetable mutation available, you can go for immune checkpoint mediators like PDL1 therapy. Okay. Any doubts in non-small cell lung cancer? Any doubts? Okay, this is very difficult to, you have to read to assimilate the concepts. Any doubts? I think I need another 30 minutes. You want lunch break or shall I finish? And probably around 25 minutes.
Sir, no one has any doubts, so you can continue.
Okay. Okay, I'll just finish it. Okay. When you got the small cell lung cancers are classified or the neuroendocrine tumors. There are 20% of the lung cancers are the neuroendocrine tumors, of which the small cell lung cancer is a major type. You can have other varieties includes carcinoids, neuroendocrine carcinomas. What is the relation of small cell carcinoma to the smoking? Small cell lung, very rare to find a small cell lung cancer without tobacco exposure. 97, nearly 100% of them are associated with a tobacco exposure. Okay. Usually they present with endobronchial irritation. They can have a hemoptysis, dyspnea, usually the obstructive pneumonia. There are also local other factors that can have is a hoarseness, phrenic nerve palsies, esophageal compression, SVC syndrome. The pathology plays a very vital role. 1 minute. Sorry. Usually, the metastasis plays a very important role. Okay. The squamous cell carcinoma, lung cancers are very aggressive tumors where there are greater than 10 metastases are present in a per 2 millimeter square feet. Whereas the typical carcinoma tumors where you have very low metastatic group where it is 0 to 1 metastasis are present. Atypical carcinoids are in between where they present between 2 to 10 metastases. Small cell lung cancer, aggressive tumors, they have definitely have a necrosis. Usually the cells are small, that is less than 3 small distinct lymphocytes. Remember that small lung neuroendocrine markers, immunohistochemistry shows they are positive for the neuroendocrine markers, particularly this chromogranin, synaptophysin, and CD56. TTF1 is positive in 85 to 90% of small cell lung cancers. Okay. So the morphological diagnosis is very important before doing for IHC. TTF1 is positive in adenocarcinoma also. The K67 is high proliferative index. What is the incidence of combined small cell carcinoma? Usually combined small cell carcinoma is combination of small cell lung cancer with non small cell lung cancer. It consists of 28%. This terminology is important. There is no minimal percentage of non-small cell lung cancer recurred. To name it as, there it recurs as 10%. 1 minute. So what is false about small cell carcinoma? Yeah, very good. So usually small cell carcinoma presents as a large central mass. Because of the central mass, they can have a superior vena cava obstruction. Distant metastasis is common, particularly brain mets, adrenal mets are common. Okay. So they occur in the central part of the lung. What is false about the paraneoplastic syndromes in small cell lung cancer? Okay, very good. So small cell lung cancer accounts for at least 75% of the tumors associated with SADH. Okay. Usually, this SADH needs fluid restriction and the demicrocycline can be used for refractory hyponatremia. There are also 5% of cases can be associated with Cushing syndrome. So small cell lung cancer with Cushing syndrome is a poor prognostic factor. There are various neurological paraneoplastic syndromes can occur with a small cell lung cancer, particularly neuropathies. It can be sensory motor, or autoimmune neuropathies. Usually, these endocrine paraneoplastic syndromes have some response to the anti-neoplastic treatment, but non-neurological paraneoplastic syndromes, where many of them are considered to be a irreparable process. So what is false about the paraneoplastic syndrome? Equal incidence with non-small cell lung cancer. What is not part of? Limited staging. There's something called as BALST staging, where it is tumor is confined to one hemithorax with involvement of the ipsilateral and contralateral mediastinal nodes, involvement of the ipsilateral supraclavicular nodes, or ipsilateral pleural effusion, or known as limited disease. This is the practical aspect of the staging process. So limited disease is tumor confined to the one hemithorax, involvement of the ipsilateral and contralateral mediastinal nodes, involvement of the ipsilateral supraclavicular nodes, and ipsilateral pleural effusion. Limited disease. Anything other than this are known as extensive disease. Now, usually 2/3 of the patients with small cell lung cancer present with extensive disease. The question is, which is not part of limited stage of BALST staging. Usually, all small cell lung cancer need is an extensive evaluation. Remember that small cell lung cancers are considered more towards a systemic disease rather than the local disease. You need to have a CT of the abdomen, pelvis, chest, bone scan, MRI of the brain. I'm not talking about symptomatic patients. I'm taking about routinely only. Bone marrow biopsy in patients on peripheral smear with unexplained thrombocytopenia and neutropenia. This is very important. Staging should not focus only on sites of symptomatic disease. There can be brain metastases which are not symptomatic. There can be bone metastases which cannot be symptomatic. Small cell lung cancer goes in very few days. The rapid rate is very fast. I mean, the doubling rate is very fast. So that's why better to do the evaluation process very fast. PET scan is very useful. It upstages management in, I mean, changes management at least in 20 to 27% of the patients. For brain, MRI brain is the most common imaging modality. Remember that the age lesser than 70 years and female gender are considered as a good prognostic factors. The poor prognostic factor are paraneoplastic Cushing syndrome, which I already discussed. Elevated serum lactate DNA, with this is elevated when there is a rapid cell turnover. Coming to management, always when the very early stage 1, you can go for a, that is less than 3 centimeter tumor. You can go for a surgery with lymph node dissection. All small cell lung cancer needs chemotherapy. Stage 1 to stage 4, they need, because as I told, it is considered as a systemic disease. There is no role for neoadjuvant treatment. If patients having N2 or N3 disease, they have to plan for concurrent chemoradiation. When you operate, you find the N1 node. In adjuvant, you also can consider postoperative mediastinal radiation. Here, the chemotherapy is very simpler. It is cisplatin and etoposide. Usually 4 cycles. If a planning as a concurrent chemoradiation, start radiation along with chemotherapy. So very early stage, you can go for surgery followed by adjuvant treatment. If there's a N1 or node, you can consider as radiation. All other disease, you can go for a chemo, concurrent chemo radiation. Radiation is preferable to give a twice daily radiation with 6 hourly apart. Because of the rapid growth of the tumor, it's better if you can give a rapid radiation, it will be useful. So remember that these patients can have a can have a neck no I mean the brain metastasis. So in both the limited stage disease and the extensive disease, it is useful. Usual dose is 25 gray in 10 daily fractions. But any brain variation can cause neural impairment. So standard of care for very early stage small cell lung cancer is a surgery followed by chemotherapy. So extensive stage small cell lung cancer needs etoposide, cisplatin. Now they have added this new regimen at 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 atezolizumab, which is now has become the standard of treatment. When the small cell lung cancer it's a relapse, you have to think like a ovarian malignancy, where if the relapse is greater than 6 months, you can go ahead with the same regimens. If it is a relapse is lesser than 6 months, uh, you can go for second line treatment. Bronchial carcinoids, which is false about bronchial carcinoids. Any guesses? Yes. So lung is the second most common site of carcinoids. The pulmonary carcinomas constitute 2% of all primary lung cancer tumors. 75% of carcinoids are central, whereas 25% can occur in the peripheral. As we already discussed, pulmonary carcinoids rarely occur in associated with Men's syndromes. %15 of the carcinoids are atypical. Usually, typical carcinoids are younger than the patients with atypical carcinoids. So, difference between that is typical and atypical, as we already discussed, it's the mitotic count. See, necrosis occurs when there is a very aggressive growth. So that's why the small cell lung cancer has a large necrosis. But necrosis also can occur atypical carcinoma because of it is intermediate aggression. Can have it is a punctured type of necrosis. K67 is not a criteria in the evaluation, but it can be used for just to find out the to provide an indirect status about the tumor. So it is the second most common site of carcinoids. 2% of the lung cancers. Atypical carcinoids are not common. Typical carcinoids are common. They are not contributed to smoking. There is also a rare condition known as deep neck, where you have a multiple small carcinoid tumors in the wall of lung. That is known as deep neck. You can have so usually these aggressive genes are not commonly seen, like TP53, RB1 are not commonly seen in this type of carcinoid tumors. Usually, the histone modifiers are not commonly seen in carcinoids. Which of the following clinical description is false regarding bronchial carcinoids? So usually hemoptysis can occur between 10 to 20%, but most of them will present with the obstructive pneumonia because they occur in the more common in the main bronchus areas. The carcinoid syndrome occurs in 8% of the cases. The Cushing syndrome is very rare. They are the most known cause of extrapituitary secretion of GHRH. So Koszner syndrome occurs in 8% is correct. Cushing syndrome is there is correct. Most common known cause of extraocular secretion of GHRH correct. 30% is asymptomatic correct. Hemoptysis common syndrome no. Okay. Usually the PET CT scan is useful in very aggressive variants like small cell lung cancer. But when it comes to the typical carcinoids, the PET imaging are not useful. You can use the Rotanate scan for the diagnosis. So pulmonary carcinoids also classified according to AGCC classification for lung cancers. Surgery is the main treatment. So if possible, limited resections can be attempted. Also needs a mediastinal lymph node dissection. So this shows the survival pattern of typical carcinoids. When it occurs in the stage 1, it is 93%. This shows how good is the typical carcinoid is. But when you can see the comparison between typical and atypical, you can see the survival drops down. Okay. This is the comparison between typical and atypical. So stage 4, somatostatic analogs as the first line of treatment. You can use lutetium 177. So the final topic, last 4 or 5 slides only. So large cell neuroendocrine carcinoma, which of the following is false regarding LECNAC? So LECNAC is a recent terminology which is diagnosed in 1991, where the high-grade tumor, which is the big neuroendocrine features. Remember, they should have macroscopically identified histological features to confirm it is as a LECNAC. Most of them are cigarette smokers. There had been a criteria to diagnose. One is the neuroendocrine morphology, mitotic rate, non-small cell cytological features, neuroendocrine differentiation by IHC. So usually adenocarcinoma is combined with the neuroendocrine carcinoma, usually, not the squamous cell carcinoma. Usually these paraneoplastic syndromes are not common with LECNAC. They generally present as the peripheral based tumors. Remember that the survival of LECNAC, that is large cell neuroendocrine tumor, is significantly worse than the non-small cell lung cancer. So that the surgical treatment will be like non-small cell lung cancer, whereas the chemotherapy regimens are usually extrapolated from the small cell lung cancers. Thank you. Any doubts you want to have? Is it clear or is it confused? Is it okay? Have you understood?
I again request all the students to please answer the sir in the comment section or in the chat box, please.
Thank you. Thank you. Please go back and read it, because if you go and read with this knowledge, you can consolidate. Because every time this is like a basic push. You can just try to consolidate your understanding. Okay, there are also some things I could have missed it, but most for exam based, most of things are covered. Okay, thank you, thank you. If any doubts, please just be on touch.
Okay, sir. So
Thank
it
you very
was
much.
an amazing session. We loved it, and we also got very positive reviews from our students as well. So we hope we'll meet you next time again with another amazing session. Thank you so much. Thank you. And,
Thank you.
and you can also ask doubts to sir through email or WhatsApp group as well. They'll be replying to you on that as well. Thank you so much.
Thank you.